Afternoon, and we thank you all for staying with us for the afternoon. We are about to have the last segment of our presentations for the Women's Health Awareness Day here in the Media Center, and we appreciate everyone's attendance. We will ask that you complete an evaluation, and there are also raffle tickets because since you stayed and you will participate, meaning you completed your evaluation, you will be eligible for a raffle drawing. So please hold tight. We want to say hello to all of the sites that are still with us and viewing virtually. So hello. And you are in the right place if you came for caring for your kidneys, what every woman should know about kidney health. Today we have Dr. Emily Chang and also Dr. Anisha Gerber, who will be with us. And I ask that you give them your undivided attention, and there will be time for question and answers, and we will invite them to come up to the stage now. Thank you.
All right, thanks for staying. I know it's been a very long day. I'm Emily Chang, and I will be talking to you about kidney disease. And we want to start just by showing you some faces that may be familiar to you, and maybe you knew and maybe you didn't know that all these people up here have something in common. And because you know the topic of my talk, you probably can guess what it is, that all these people have kidney disease. So it's the point being, it's out there, and people who are living normal, healthy, vibrant lives have kidney disease. So it's sometimes in disguise, and we're going to get to that in a minute. This slide is to show you just how prevalent kidney disease is. So in America, 37 million Americans have kidney disease. And there are a bunch of statistics here to kind of highlight just how prevalent it is. But I want to point out a few of them. On the left there, 9 in 10 adults do not know they have kidney disease because it's a silent disease for the most part. And then underneath that, 33% of the people on dialysis in the United States are Black, even though Black people comprise 13% of the nation's population. So that's out of proportion. Kidney disease affects Black people, Black and brown people, more than other people. And then here, 33% of patients initiating dialysis live in zip codes with greater than or equal to 20% of the population below the poverty line. So affecting Black people, affecting people of lower socioeconomic status. So this is a real problem here. And then last year I gave this talk with Dr. Keisha Gibson, who is a pediatric nephrologist, and my colleague Anisha, Dr. Gerber here is the pediatric nephrologist. But she always leads in with this great personal story she has about something about home dialysis. So I don't know if and many of you have friends or know people who have kidney disease who are on dialysis, but a lot of people do know people who go to dialysis but don't know that you can actually do dialysis at home. And her story that she always presented, I'm sorry you don't get to hear it, but it's quite a compelling story about a family member of hers that was not offered home dialysis. And sometimes that happens, that you have to advocate for yourself. Doctors can come in with biases and preconceived notions and don't offer all the alternate options, and instead just kind of pigeonhole people. So home dialysis is a great option, but it's 40 to 50% lower among Black and brown people compared to white people. So we just need to make sure, as us as professionals are trying to overcome some of these barriers. And this is the kidneys. You might wonder, just in case you don't know where they are located kind of most people have two kidneys in your lower back right here. And this is an example of what a kidney looks like with the arteries going into the kidneys and the veins coming out. And the magic happens in that kidney tissue where the blood comes into urine, and that's why it looks yellow. And that's the tube that leads from both kidneys down to the bladder and then the bladder out. And what do the kidneys do? Oh wait, go back. So probably you're well aware, kidneys, like I showed you, the magic happens, blood turns into urine, so it makes urine. And most people will tell you, okay, kidneys filter blood. And yes, that is true. But the number of patients that come to my clinic and I start going over the things I'm looking at in addition to how well it's filtering or cleaning, and people do not realize all the things that the kidneys do in addition to filtering blood. So it maintains fluid balance. By that I mean, so you don't get puffy and too much fluid or too dehydrated and fluid down. It also works to keep your electrolytes normal. We eat foods, we eat things that have electrolytes in them, but we have to keep them in the perfect balance so your body works right. And the kidneys help to maintain that balance when you have too much of something to get rid of it, too little to hold on to as much as possible. And it maintains normal acid-base balance. So again, your organs need to have the right acid-base balance in order to function correctly. And the kidneys help to maintain that. And then this is the filtering part, cleaning waste materials from the blood. And then also, it stimulates the bone marrow to make red blood cells. Who knew that the kidneys are also participating in that part of keeping your body healthy? And then this one also surprised people too. Kidneys are part of bone health. And so that is because they help control calcium and phosphorus and how much is absorbed and secreted. And that helps to keep your bones healthy, which, as we know, is very important, particularly for women. Also participates in controlling blood pressure. So if you have blood pressure issues, your primary doctor often takes care of it. But some of you, or you may know people who have heart doctors and kidney doctors that help take care of blood pressure. Yes, Devon. Yeah, so the question is the calcium portion that I referred to, is that what causes the kidney stones? And calcium is definitely a contributor to kidney stones. We have different kinds of kidney stones, and calcium is one of them. This that we're referring to here is a little bit different. It is sort of related and not completely related, but kidney stones and calcium are definitely an important part of kidney disease. And so then that's what the kidneys do. What kind of things cause kidney disease? So here in the United States, and this is really true worldwide too, your main cause, so 43% of the time, the cause of kidney disease is diabetes. So that is our number one cause of kidney disease. Number two, at 25%, is high blood pressure. And the number of people that have both of those is very high. So you got a double whammy then putting you at risk of kidney disease. And then there's other, and that it would include kidney stones, other medicines that might have hurt your kidneys. And then the little category there, GN, is a special kind of kidney disease called glomerular nephritis that is different causes for that. I think you just had an autoimmune talk. Autoimmune causes go into that category. And then if we're talking specifically about kidney disease in women, which we are today, CKD, or chronic kidney disease, affects approximately 195 million women worldwide. And it's the 8th leading cause of death in women. And while diabetes is the most common cause, women experience kidney failure more often when they have lupus nephritis, so lupus affecting their kidneys, and pyelonephritis, which is an infection affecting the kidneys. And then kidney disease from pregnancy-related complications is also a big concern. So women have a little bit more, a little bit different of landscape of kidney disease compared to men. And then this is an interesting topic that's sort of just now becoming utilized clinically. We've been researching it for years, but there's something called ApoL1, which is a gene, and we believe it's associated with kidney disease in patients of African American ancestry. And it has to do, actually, it's a really interesting story, but it has to do with certain protective mechanisms it has against certain infectious diseases. Quite a complicated story that led to how we understand about it. But about 1 in 5 people with 2 copies of this risk allele will develop kidney disease. And they account for 70% of patients without diabetes-related kidney failure in African Americans. And about 4 in 10 African Americans on dialysis have kidney failure caused by this gene. So we're very interested in understanding more about this gene. And I was just telling Dr. Gerber, I just recently got a flyer about LabCorp doing free testing for this gene now. So we can utilize that to better understand our patients and their risk of kidney disease. So how do we measure how your kidneys are functioning? Well, the kidneys filter 130 to 180 liters of blood per day, which is about equal to 3 to 4 ounces of blood a minute. And then we call this the glomerular filtration rate, or GFR. And if you get a lab printout from your doctor, you actually will see GFR. Usually there's a little E in front of it. And what that's talking about is how well your kidneys are functioning or performing. And they call it, the G is a part of the kidneys, and that's where the filtering happens. So that's where that G word comes from. So glomerular filtration rate. And in most people, this number is about 100 or 130 milliliters per minute. And GFR is estimated, so that little E goes in front of it, by measuring the creatinine in the blood. So another thing you'll see on your blood panel is the creatinine. So those two are very tightly related. They're actually, thank you. They're actually, one is used to calculate the other. So when one goes up, the other goes down. They're very, very closely related. And when you look at the creatinine, this is important to understand, but also for doctors to be able to explain this to you. So in this picture on the left, you have an older woman, and this one you have on the right, a very young, very fit man, and their lab test, when they looked at their creatinine, is the same. But when you calculate it with that equation to get the eGFR, it was very different. You get a very different answer for the 2 different body types, genders, and the reason is because that equation takes into account your age, your gender, different things, your body mass, and so it gives you a very different level of function. So that's why we use both of them, both creatinine and eGFR. And even then, the eGFR is sometimes not enough. So again, we contrast two. On the left, these young people, probably maybe even people here during the week, and they have stage 3 CKD, which is based on the GFR. You designate a state based on the GFR number. On the right here, you have older, let's say, more mature people, and also with an eGFR 45 and stage 3 CKD. Well, that means very different things for these two groups of people. And actually, I tend to see a lot of more of these people than those people. And if you think about it, if you are at stage 3 and you're 85, well, that's very different than being 20 and stage 3. Because when you're 85, man, you'll live another 15 years, you know, maybe 20 years. These days, people are living longer. But when you're down when you're in your 20s, I mean, you've got 80 years left to live, and you only have that much of kidney function. So it's a very different thing to think about. And when I'm talking to my patients, I'm very cognizant of the age and how that relates to their GFR. I just was talking to Dr. Gerber about a patient I saw Friday who was exactly this patient here, a GFR of 48 and 83 years old, and she was very nervous and thought, oh my gosh, I'm in danger of dialysis. What is she going to tell me? And her blood pressure was higher than it usually is because she has a UNC doctor. So I could see her older blood pressures, and it was 20 to 30 millimeters mercury higher on the top number. And I thought, that's from anxiety, because that often happens with the first visit. But I explained to her that a GFR of 48 at age 83 is actually pretty good. And you don't have the risk factors. You don't have a lot of the risk factors. The things you're doing are controlled. And you could see the anxiety go just like wash away from her. Now, if I saw a 20-year-old, I'd say, okay, we really need to get this under control because I need to tell you what you're facing down the line. But it's a very different conversation between these two patients with the same number. So it is very important to have that individualized conversation with your doctor. And we have a little card that says, hey, doc, how are my kidneys? And these are the numbers that we like you to look at. Your blood pressure, because I told you hypertension, which is the fancy word for high blood pressure, is the #2 cause of kidney disease, so know your blood pressures. Diabetes is the #1 cause, so know your A1C, your hemoglobin A1C. That's how well your diabetes is controlled. And then know your cholesterol. We didn't get into this, but kidney disease is a big risk factor for cardiovascular disease, which means heart attacks and strokes. So it's important to have your cholesterol controlled. And then what's my BMI or body mass index? Because that is also important as far as a risk factor for progression of kidney disease. And then what's my GFR, which you just learned about. And then what do you do if you learn you have chronic kidney disease? Well, chronic kidney disease in general is a lifelong thing. It's a disease, but it's something that you control, you manage. It's not it is a risk factor. It's what we call a comorbidity, but you manage it, you control it, and these are some things we can do to help treat it. Control the blood pressure, because even if you had high blood pressure causing the kidney disease, if you have controlled blood pressure, it's lower risk as far as making your kidneys get worse. Keep your diabetes under control, same thing. Even if diabetes was the cause, controlled diabetes has less of an effect than uncontrolled. And then we protect you from bone disease. That's going back to the slide of what the kidneys do. We're looking for bone disease. Anemia, which is low hemoglobin, we're looking for that too and treating you for that. Fluid intake, and it's not necessarily limit, but it's we guide what we want you to do. And at different stages in your disease, you may want to be advised to drink more, at other stages less. And then if things continue to get worse and you to the point where you do start to feel it and it's no longer silent, then we have things to offer like kidney replacement therapy, which includes both dialysis and transplant. And when you get to that point too, we may have dietary restrictions, so things in your diet that we want you to adjust to make it so that you don't feel as bad. And a lot of patients will ask me this, well, not even patients, just people, like, oh, you're a kidney doctor? What is a kidney diet? And there really is no such thing. So each patient has different requirements, and it depends on what your labs show. So that's why it's individualized. Talk to your doctor. And then the enemy, the one we can tell everyone to be wary of is salt. Salt is not good for kidneys in general. And Dr. Gibson loves to break it down into the different kinds of salt, but it's very helpful to think about all the hidden foods that salt comes in. And reading food labels is important, and you set your sodium consumption goal to 2,500 to 3,000 a day. And Dr. Gerber?
All right, thank you, Emily, and thank you all for taking the time to be here. Javon, I saw you giving us the time check-in, so I'm going to try to triage some of these slides and hit the highlights. But we're going to pivot a little bit to talking about what happens when we try our best to prevent kidney disease or prevent progression of kidney disease, but kidney disease does progress, and that is at the very end of the spectrum, which is CKD stage 5. Sometimes you'll hear us call it end-stage kidney disease or end-stage renal disease. And the most important point we wanted to make is that fortunately we have therapies that can come in and do the jobs of the kidney when the kidneys are failing. These therapies are dialysis or transplant, and we'll talk a little bit more about them in the coming slides. But Dr. Chang also mentioned she sees a lot of older patients, and for them, perhaps the answer is not dialysis or transplant, but supportive care or palliative care, where we manage symptoms of kidney disease and focus on making the patient as comfortable as possible. Like I mentioned, for most people, dialysis or transplant are good options that allow them to continue living their lives and pursuing their goals. Hemodialysis is blood dialysis, where people come into a dialysis center 3 times a week to have their blood cleaned. Most adults will go through a minor surgery to have a vein created that's strong enough to do hemodialysis. A lot of the children I take care of are too small for that, and in those cases, or if there's emergency dialysis that's needed, we'll put a catheter in a vein in the chest or neck to do hemodialysis. And it's inconvenient coming into a dialysis center 3 times a week. And so, just to reiterate what Dr. Chang said, home hemodialysis is becoming more widely available, and if this affects someone that you love, it's something to ask them about, ask their providers about home hemodialysis, which can work itself into a person's lifestyle more easily. Just know that peritoneal dialysis is another type of dialysis. A lot of our children are on it because they can go to school during the day, and then overnight they're connected to this machine that puts fluid into their bellies, allows for the exchange to happen between the fluid and the blood. The blood gets cleaned, the waste fluid is drained, and this process repeats itself overnight. And they wake up the next morning and go about their day again. And then kidney transplant, it's a gift. It is something that we want for all patients who would benefit from it. It does come with a large medication burden. Patients will be taking medications for the rest of their lives to make sure that their body's immune system doesn't attack this new transplant kidney. And this is an older graph that I left in here because it does illustrate that there are more people on the kidney waiting list, the red line, than we have kidneys to go around. And so it's important to talk to your nephrologist early if you have CKD 4 or 5 to talk about when to start the transplant evaluation process, to maybe avoid dialysis or minimize time you're on dialysis if you can get through the transplant evaluation process early. And on average, a deceased donor kidney lasts about 10 to 12 years, but that varies a lot based on the patient. All right. And then I'm just going to fly through these so we can make sure we have time for questions. But kidney disease is silent until very late stages. So this highlights the importance of showing up to our annual physicals and following through on the plans that we come up with our healthcare team. Okay, great. Thank you. And then I'll focus here on risk factors that we can modify. We talked a lot about how age affects our risk for CKD. After age 35, all of us lose 1% of our kidney function every year, even with healthy kidneys. Other risk factors that we can't change are our ancestral history that goes along with the APOL1 risk status that Dr. Chang talked about. And then people of color in the United States are at increased risk for kidney disease, especially African Americans. And so just keeping your healthcare providers, us accountable for assessing risk and monitoring accurately is super important. The things that we can modify are lifestyle changes that'll help us control diabetes, hypertension, reduce our risk of acute kidney injury. I describe acute kidney injury as like a cut on our skin. With just one cut, our skin can probably heal. If it happens over and over and over again, our bodies have a harder time bouncing back. So what we can do to avoid acute kidney injury, one of the main things is to stay well hydrated, drinking mostly water, and then avoid overusing non-steroidal anti-inflammatory drugs like ibuprofen, aspirin, ibuprofen-containing products like Advil and Motrin. These are great medicines for inflammation or for fever, but if we use them too much, they can cause kidney injury. So how do we prevent chronic kidney disease, or how do we prevent progression of it? These are things we already know about, like how to stay healthy. Eat a balanced diet, don't smoke, move our bodies, control diabetes, blood pressure, don't overuse the over-the-counter drugs that are readily available, and reduce stress. And I'm looking around the room and I imagine, like, all of these things are easier said than done, but I imagine that y'all have a lot of hats that you wear throughout the day, a lot of people counting on you. And so just remember to put yourself first sometimes, self-care, so that you can do a lot of things in life, including, take care of those people who need you. And then the next step beyond knowing your numbers, like Dr. Chang mentioned, is having that conversation with your doctor and making sure they're not just, rushing through the day, but asking, is this normal? What can I do to help get it normal? Those are the next questions. If we can diagnose CKD earlier, there are medicines we can use that have been shown to slow the decline of chronic kidney disease. Some of these are SGLT2 inhibitors, ACE inhibitors, lisinopril is one that people are often on, and then angiotensin receptor blockers. Okay. And then if y'all go on the internet and you search for UNC kidney scorecard, this will come up and you can punch in your own risk factors and it'll give you a nudge about when you should see your primary care doctor and the time frame in which you might need kidney disease screening. So that was a ton of information, but if there's one take home, it's the question that was on the back of Dr. Chang's t-shirt, which is, hey doc, how are my kidneys? Ask your doctor, have that conversation. We want to diagnose people early and keep them healthy for as long as possible. All right, so with that, we'll take questions.
Any questions?
Yeah.
Just a second. If you can ask your question in the microphone and stand, please. Did you put up remote?
Okay, so my question is PKD a type of CKD?
I'll take that one. And by PKD, do you mean polycystic kidney disease? Okay, so PKD is a genetic and the most common genetic cause of kidney disease. And it does cause CKD. So CKD is a very general term for anyone with chronic kidney disease of any cause. But PKD is one specific cause. And yes, they do experience chronic kidney disease. And I'll put in a small plug. We did just we at UNC have a PKD Center of Excellence, the only one in North Carolina. And I am one of the co-directors. So if you know anyone with polycystic kidney disease, we would like to see your patient. And there's very specific things for polycystic kidney disease patients that are different, a little more specialized than basic chronic kidney disease. So we're asking a little more detailed questions about certain things. and polycystic kidney disease can affect other organs in a different way than chronic kidney disease. So we're asking about all those things. And there is one approved medication for that to prevent progression. So we're kind of figuring out if that medicine is right for you.
Just to add to that, as our genetic testing improves, some people know that they have polycystic kidney disease when they're 10 or 15. And, we, as pediatricians, our goal is to keep them at a healthy weight, manage their blood pressure, just help them establish healthy habits as teenagers before we send them Dr. Chang's way as adults to talk about the therapies that are approved for adults.
Hey, thanks so much to you both, and also congratulations there. But I wanted to ask, I think you mentioned earlier that after a certain age, we all start to lose some functionality of our kidneys. And I'm assuming that with the preventive methods that you talked about, we can kind of keep it at bay. But is there a percentage that we move towards in terms of having the various stages of kidney disease with just a normal progression?
Yeah, so I'm curious to hear what Dr. Chang tells her patients. I tell mine that around the age of 35, we all start to lose about 1% of our GFR every year. And with chronic kidney disease, so with something that is making the kidneys sick, it's hard to predict when that decline will start. It might start before age 35, and it's hard to predict what the rate will be. It might be more than 1% every year. So you're exactly right. With those preventative strategies that we mentioned, our goal is to slow that decline and honestly keep kidney function as stable for as long as we can.
And you can't really stop nature. So your kidneys are going to age, just like your hair turns white. Your nails get more brittle. They are going to age. So I'm not surprised. Like that patient I told you about is 83, GFR 48. When I did the numbers, what Dr. Gerber was talking about, losing about a point a year, when we calculated it based on her age, I only expected her to be around 50. So when we talked about that too, I said, see, you're really actually, it sounds low, but you're actually just a little off of where I'd expect you to be for your age. So you can't change that part of aging is aging. We don't, or maybe we can in the future, we don't have that yet. But if you stay on pace with normal without these other things like diabetes, high blood pressure, then you can kind of expect it to be on the normal pace. And we don't really measure from 100 to 130, I said was the normal, and that's when you're healthy at 30. We can't really measure from 60 to 100, to be honest. Our blood test, the creatinine to the eGFR, it doesn't, you'll see on there it says greater than or equal to 60, because of above 60, that's not accurate. So I don't know what's happening above 60 without doing a more involved test.
Okay, so my children's grandmother's 85, and maybe 5 years ago she had one kidney removed because of cancerous cells. So my question is, if you remove a kidney, does the other kidney work twice as hard? And if someone had PKD and there's cysts on one kidney, would the answer not be to just remove that kidney?
Do you want to go? Go for it. Okay. So that's a great question. Okay, so let's start with the removing a kidney. You can live with just one kidney. So the kidneys are redundant, and that's why people can donate a kidney, because you don't need two kidneys as long as you're healthy. If you don't have high blood pressure and diabetes, like we won't let you donate if you have risk factors. But, and then there are people who, and when you get a transplant kidney and your kidneys aren't working at all, you're living with just one kidney. So there's a lot of redundancy built into that system. I really don't know why evolutionarily, because did it design itself so we can donate? I don't know. But so it will depend on other things, and the other kidney will try and compensate. So it actually does like grow a little bit to try and make up for that. And There are some things, though, if you have a kidney taken out, like for a cancer or something, that you do need to watch out for, especially if you're older. If you didn't have high blood pressure before, taking away half of your kidney tissue may lead to high blood pressure. So high blood pressure is a cause of kidney disease, but also an effect. So don't be surprised if then you develop high blood pressure when you have a kidney taken out. And then your other question was about the cysts. Oh yeah, so if you have cysts on just one kidney, so that's a little bit unusual for we do see it. That's an atypical polycystic kidney disease variant. Usually when you have the typical polycystic kidney disease, you have cysts on both kidneys. And we actually, we don't take those out unless they're causing a problem, even when they get the patient gets a transplant. If you have cysts on just one kidney, I wouldn't take it out either, even if the cysts are growing, because the operation to take out a kidney is actually more involved than the operation to put in a kidney. So we don't take out a kidney unless we feel the benefits outweigh the risks. And that is true for cancer patients and sometimes polycystic patients. If the cysts and the kidney is growing so large that it's pushing on things and hurting, like causing a lot of pain, or cysts are rupturing constantly, or you're getting stones, things like that, then it may be worth it to take the kidney out. But if it's not causing problems, we don't take it out because it may still be working a little bit, and we want to get everything out of it that we can.
I have a question. I have a friend that has had both kidneys removed and they're on dialysis. They're waiting for a kidney. How long can the body sustain going through dialysis and not having a real kidney?
That's an excellent question. I guess there's a few parts to that. One is that the kidney waiting list for adults, the wait time on average is 5 to 10 years, depending on your blood type, depending on if it's your first transplant. And so it's long. There are people who stay on dialysis for decades. Actually, I was just at a talk where the social media director for one of the main dialysis companies said that she herself has been on dialysis for 25 years. That being said, it's hard on the body, it's hard on the blood vessels. People often leave dialysis not feeling so well while their body re-equilibrates. So we do everything we can to get people through that transplant evaluation and then talk about ways to help them get a kidney as soon as possible.
And one last question from the facilitator. Is there any research or any discussion on the effects of menopause and how the kidneys act?
That's an excellent question.
Yeah. Yes. I don't know it because I'm not involved in that part of research, but absolutely. I think that menopause, as with everything, affects everything in our bodies. And like going through it right now, and it's affecting a lot of things. And kidneys would be one of them. I don't know the research on it, so I don't know if you have any more up to date.
Okay, what stage do you start medications? Because my sister, she's on stage 3, but she's not on any kind of medicine, so I was just wondering, should she be on anything or what?
Yeah, it varies person to person, and there are plenty of people with chronic kidney disease stage 3 who aren't on any medications. And I think that makes it even harder to show up to doctor's appointments if we're just sitting there chatting. But the important things that happen are measuring blood pressure, looking at urine to see if there's protein in the urine to determine the best time to start medications.
And Dr. Gerber showed the slide with the medicines that we use, and you may be seeing these ads. So I get patients come in, how come I'm not on this one? It's like, protects your kidney disease. It's like Jardiance and Invocana. I guess I'm not supposed to say names, but like, But the commercials say, oh, do you have chronic kidney disease? You should be on this medicine. And that's great. I'm glad that the patients come and ask me, should I be on it? But it's not right for everyone. So don't necessarily jump to it and think, oh, my doctor's not doing the right thing because they don't have me on it. There's certain patients that should be on it, and those patients it's very good for. And we're trying, at least at UNC, we're trying all these initiatives to try and make sure every patient that should be on it at least understands they should be on it, and then they can make the decision. And there's one other medicine that I think very soon will be able to be added to that slide, and you've probably seen ads for them too, is these popular weight loss diabetes medicines. So we are also, I didn't use a name, we're also, I think the data is about to come out that it's protecting the kidneys too. So we may have more in our, so this has all come about in the last decade plus, like that we finally have these things, they don't fix the kidneys, but they slow it down. And we didn't have, for many years, all we had was lisinopril and losartan. Those are generic names, so I can say them. And for many years, that's all we had. So it's kind of exciting now. We have more things, which can be burdensome to the patients. They're like, why am I on 4 medicines? Like, well, we have these things that now that can protect you, so we didn't have anything before.
I think that it's time for us, if you don't mind, please complete your evaluation. For completion of the evaluation, you get to have your raffle ticket dropped in the box, and we have one gift left for our attendees. When you finish, please head over, if you still have time, to the theater. There's going to be more raffles, and that's the closing ceremony. We just want to say thank you to Dr. Chang and Dr. Gerber for giving us part of their day and a lot of information on kidney disease, and just to be equipped when we go to the doctor what questions to ask. So thank you so much.